Okay, so let's talk about coronary artery disease. Um, Remember that the heart itself, I'll draw my Valentine's heart up here, it has to have blood supply to feed the actual muscles. Remember, it's working all the time, so there's a left and a right coronary artery, and then those branch, and the idea is to give blood flow and nutrients to the actual muscle tissue of the heart. It's separate from, the blood flowing through the ventricles and the atria. It's separate from moving through the chamber. We're talking about blood flow directly to the cells to keep that heart full of oxygen and nutrients that it needs. If we block those, then part of the heart can die. Okay? It's like a stroke occurring in the heart, or some people call a stroke a brain attack. But either way, you've blocked blood flow. So coronary artery disease, any vascular disorder that narrows or occludes the coronary arteries, which can lead to myocardial ischemia, so blocking blood flow. Okay? Atherosclerosis is the most common cause. Risk factors, some of the things, again, that you can do something about, and some things that you can't. You can't do anything about your age, family history, or your gender. Things you can do something about is control the lipids. Okay, so if you control the LDLs, then you're going to decrease the chance. One other thing you can't do a lot of times is control the size of those LDLs, and that's kind of a genetic component. But you can control LDLs overall with various diets. Hypertension in general, from that vessel damage, cigarette smoking, diabetes. If you treat diabetes or if you avoid type 2 diabetes, that kind of works together. Obesity, sedentary lifestyle, and then an atherogenic diet. So that's any diet that's going to cause an increase in the LDL. And so really we look at diets where you can avoid atherogenic, so they kind of work against or with each other, against each other, whatever. So let's talk about chronic. So what happens when you have a partial blockage of coronary arteries and it's just sort of there? Okay, so we have maybe some stable plaques that are there. They have the fibrous coating, but they're kind of compromising blood flow to parts of the heart. So what can happen are the anginas. So stable angina, and this is kind of oddly named, but stable angina is from stable plaques. Okay, so we have a stable plaque. We know it's causing partial blockage, and this happens when somebody is out mowing the lawn. Okay, so you can kind of picture that. Somebody's mowing the lawn and they exert themselves just enough that the heart is saying, hey, I need more oxygen. This guy's really working hard. I need more oxygen, and the coronary artery is saying, sorry, we're kind of clogged. And so those cells of the heart start to notice, and then that will generate pain. Okay, so that's pain when the heart's oxygen demand increases, and they're associated with this fixed obstruction. So these stable lesions. It's predictable. It always happens. I already used the example of mowing the lawn, but maybe walking upstairs. If you know that when you walk upstairs and your heart starts to increase, the heart rate starts to increase, that you're going to start feeling this angina. And you can relieve that by rest. You can also relieve it by taking nitrates or nitroglycerin to open up the vessels more. But it's relieved by rest. And this is really an important point. Because later we're going to talk about unstable angina. An unstable angina can't be relieved by rest. Okay, so that's a blockage that is from something more unstable, an unstable plaque or something. Okay, so that's stable angina. A Prince metal angina or variant angina is from a spasm. Okay, so it's pain from when coronary arteries spasm. So it's really not so much associated. You could have stable angina too, but it's really not from an increase in demand, because it can happen when you're at rest. It can happen at night. We don't know exactly why these vessels spasm when they do. But when they do spasm, they can cause up to a 90% occlusion, which is going to be registered as pain. Okay, so that's variant, and that's why they're different. So if somebody has routinely and it happens more than once, and they feel this angina at night or at rest, then we know that it's probably variant angina or Prince metal angina, and it's caused from a spasm. Okay, if it happens under demand, it's a stable angina. And we can kind of see a picture here. you can see that when there is a spasm that occurs in this area of the vessel, that we have just stoppage of blood flow to everywhere that was being fed by that. Okay, so that doesn't take place. And then if you take a nitrate, like nitroglycerin, then it will cause that to relax, and you have what vasodilation that happens. Okay, so variant angina associated with pain and discomfort. Oh, I think I completely skipped silent ischemia. I did. So silent ischemia is not associated with pain. Okay, so no real pain. Okay, so you're not feeling any kind of pain. You may feel some discomfort, or some fatigue, which is listed down here, but you don't, or unease, increased breathing rate, but you don't feel the same kind of pain that you would feel with angina. Okay, so the cause is uncertain, but may be associated with mental stress and vessel spasm. But the person doesn't notice it, and they usually just notice it when they're having like a stress test or some other kind of test being done. So variant angina is associated with pain and discomfort. Silent ischemia, it's some kind of evidence that ischemia is taking place, but the chest discomfort and angina symptoms are absent. Okay, so that's just what silent ischemia is. This is just to point out to you that you don't always, and that's the important point, you don't always feel pain when there is ischemia of the coronary arteries. Okay, and that's silent ischemia. So cardiac stress tests can reveal this to be taking place. And it's important because both of these, variant and silent, can and stable, all of these can put patients at a higher risk for myocardial infarction and death. Okay, so those were chronic. Okay, so these are things that people experience for an extended period of time. Acute coronary syndromes, that's where we start thinking about heart attacks. Okay, acute, fast onset, and it develops very, very quickly. So we have a couple of questions here. Let's say we have an unstable plaque in a coronary artery and it breaks free. Okay, so something happens and it forms a clot, and we have a partial occlusion. Okay, I don't know why it changed colors there, but we have a partial occlusion that takes place, and you're going to experience ischemia. That's an unstable angina. You feel the pain. It's a different kind of pain. It tends to be more intense. It can't be relieved with rest, and so that's what we consider unstable angina. So an atherosclerotic plaque that is prone to rupture is considered complicated and therefore unstable angina. Unstable angina may indicate that a plaque has become complicated, but not yet necessarily broken loose. It's just causing some blockage. Okay, it can be temporary blockage, but you know, when this is happening, there's a very, very good chance that a heart attack or a myocardial infarction could happen. Okay, so it's associated, and this is important, even though I don't consider myself an expert on EKGs, ECGs, this is an important diagnostic criteria, and that is it's associated with an ST depression. Remember, you've got the P, which is atrial depolarization, QRS, ventricular depolarization, and the T, ventricular repolarization. Not that important, but there is this segment between the S and T that tends to show what's going on. Okay, if you, or the T wave itself. So ST depression, so if you have a depression, instead of going up, it goes down, that can indicate ischemia, okay, which is going to be associated with unstable angina. So you have pain, you have T wave, ST depression, instead of going up, it's going down, and that's going to indicate, it's going to indicate ischemia. Now, injury is taking place, so that's going to be considered a myocardial infarction. Okay, so this is when injury starts to take place, and you can also kind of see what's going on. So that means we have more of a complete blockage. It can, I guess, not be completely blocked, but it can still cause, but you can get indicators that damage is taking place. Okay, so It's a sudden and extended obstruction. So these cells behind it are starting to starve, okay, of the myocardial blood supply, and you're going to be able to, so there's either, you can either have ST elevation, so going back to our EKG, we might see, instead of depression, we might see this ST segment, we might see an elevation. That's what we can see here, which definitely means that injury is taking place. Okay, so if we see an ST elevated myocardial infarction, that's what we're going to call that, an ST elevated myocardial infarction. There's really no question at that point that damage is taking place and that you need to probably get them to a catheterization lab and try to open up that vessel. Maybe give them some TPA. You know that there's a blockage and you need to clear that blockage because injury is taking place. However, what if you don't see ST elevation? What if you see ST depression? Okay. Do we know that injury is not taking place? We don't necessarily know that. Okay. So now we have a question. You might be saying, well, if there is no ST elevation, why aren't we just calling it unstable angina? Okay, that's not really considered an infarction. Unstable angina, there may not be any damage taking place at all, and that's the question. Okay, so if we don't see ST elevation, then we have some questions to ask ourselves. You know, is this an MI, or is it just unstable angina? Okay, because the treatment's going to be different. And really, we can tell that by lab results. We can test for troponin levels or creatine kinase, muscle brains, CKMB, and then we can kind of tell if damage is taking place. So let's kind of go through that kind of once more in a little bit different way. So let's start with our unstable angina. The pain is different from stable or Prince-Metal or variant. Okay, it's more persistent. It has a more severe course. It can't be relieved by rest. Okay, so in fact, it may occur at rest. So characterized by at least one of three features. It occurs at rest or with minimal exertion. So this is not our stable, your grandpa's stable angina. This is something more serious. Usually lasts more than 20 minutes, okay, unless you give nitroglycerin, which opens the vessels, which might help. It's severe, described as frank pain, and of new onset. Okay. Occurs with a pattern that is more severe, prolonged, or frequent than previously experienced. So this is kind of saying that, okay, you've been experiencing angina, you've been experiencing pain, but now you know there's something different about this. Okay, and that's what happens with unstable angina. Remember that unstable angina is an incomplete blockage. You haven't blocked everything all the way, but you do feel the pain. Okay, and it's acute. That's why it's considered under this acute category. A myocardial infarction generally result from unstable plaques, just like unstable angina can, but your EKG changes can be different. So you can have a T-wave inversion, which is ischemia. You can have ST either elevated or not elevated. Okay, but the important thing is that in this case you have injury taking place. Okay, so that's what's going to be our difference between an MI and just unstable angina, is that you know that you have injury taking place. They're all going to be ischemic. Okay, they're all blocking blood flow, but in this case you have damage with an MI, which infarction means damage, injury, necrosis. Okay, so that's why it's an infarction. So a STEMI indicates injury has taken place. So you would, in this case, if you see ST elevation, you know that it's an MI. Okay, so you administer fibrinolytics like TPA, tissue plasminogen activator. You want to break down the clot, and you would catheterize them. It's very important to open that vessel because damage is taking place. Now, if you don't see ST elevation, you still don't know. You say, is this unstable angina or is this an MI? What's happening? So ischemia is occurring and injury is imminent, but you would have to confirm that maybe with lab results to see if there's actual damage. Okay, if you don't see an elevation in these biomarkers, the troponin 1 and the CKMB, If you don't see an increase in biomarkers, then you say, okay, well, you can kind of indicate that, well, that means that cardiac muscle damage isn't taking place. The troponin 1 and the CKMB are supposed to be inside cells. So let's kind of pause on that and say, why are we looking at these biomarkers? Well, these biomarkers are normal proteins that are being made, but they're supposed to be contained within cardiac muscle. If damage is taking place, then the troponin, the CK, the creatine kinase, CKMB, will leach out into the blood vessels, and suddenly you can see it in the blood. Okay, so that's why you know that muscle damage is taking place. And so that's going to be your indicator, again, for is this unstable angina or is this a non-STEMI? Okay, that's hopefully that makes sense. I think I've said it twice now, so hopefully we got it. So what do you do? So there are some kinds of revascularization procedures. So you can put in a catheter and install a stent. There are a number of different processes to use. Balloon angiography, yeah. So, or in this case, we can see that you've put in a stent. You're doing something to open up that blockage. Okay, there's something also called a CABG, or a coronary artery bypass grafting, and that's usually if more than one coronary vessel is involved. Then you can bypass that area, and you can directly provide blood flow to the area that's being damaged or is damaged. Okay, so let's kind of go over this one more time. Acute versus coronary disease. So chronic, if it's chronic, then you have your stable angina, you have your variant or Prince-Metal angina, or you may have just silent ischemia. Okay, so those are chronic. Those are things that are happening for a long time. Acute, when it's acute, you can have non-ST elevated, and if it's non-ST elevated and there is no damage, then we'll call that unstable angina, or if there's no damage taking place or no indication of damage taking place, we'll call that unstable angina. If there is damage taking place, then we'll just say that it's non-ST elevated myocardial infarction, okay? So a non-STEMI, okay? So that's our diagnostic criteria for these. If there is ST elevation, and then we know, and we can kind of look and we can say, well, is it STEMI, or is there actual necrosis taking place? That's going to depend on how advanced it is, how serious it is. But if there is ST elevation, then that's a clear indicator that there is damage taking place. Okay, so let's move. We're going to also discuss the layers of the heart. So that was our MI stuff. Now we're going to discuss the layers of the heart. So there's this area around the heart called a pericardium. Okay, so it surrounds the heart. It kind of, well, we'll just read through the functions of this serous membrane that's kind of out here. Serous means that it's producing clear fluid. It's lubricating, for one thing, but it also isolates it from other structures. Okay, so that means the heart is not just kind of beating and just all over the place. That it actually does have a membrane around it. Maintains the heart's position in the thorax, prevents it from overfilling. It can be a barrier to infection, so it protects it, and it helps match the distensibility between the two ventricles. So both of these ventricles, the right and the left, both have to take in the same amount of blood. Okay, it's different pressure, but if you think about it, they both have to be pumping the same amount of blood, otherwise things are going to get backed up, and that's where we talk about heart failure. Okay, so the pericardium plays a role in that. And the pericardial fluid prevents friction during systole and diastole. So it kind of lubricates it a little bit. So disorders, acute pericarditis. So we're only going to really talk a lot about one of these. So, but that pericardial membrane can become inflamed, and that would be an inflammation is itis, so pericarditis. So it can be caused by infections, but in general it's just the acute inflammatory process of the pericardium. So that's when it becomes inflamed. Okay, so you could say that it's pericarditis, but you may not see any other indicators like effusion taking place. So pericardial infusion, we have another slide on that talking about cardiac tamponade, but it's an accumulation of fluid inside that pericardial sac. Okay, that pericardial the layer. Remember, it's a bilayer, and so you can see an increase in fluid, that serous exudate being produced, and it's going to collect around the heart. There's also something called constrictive pericarditis, and that's where you've had damage and scar tissue forms, and it can make that pericardium stick to the heart. Remember, it's supposed to be lubricating and the heart's supposed to be beating within it, but if there's scar tissue developing, it won't produce that sera like it's supposed to, and the pericardium can actually stick to the heart, and that's going to also restrict the heart's ability to expand. Okay, so let's talk about cardiac tamponade. It's part of this pericardial effusion, so it involves the pericardial membrane, and it's fluid that collects in this. This is a Wikipedia picture, but I really like it because it really gets the point across. The accumulation of fluid in that pericardial cavity. Okay, so you can kind of see that effusion will lead to cardiac tamponade, which can be life-threatening, and it compresses the heart. Now that kind of makes sense because you're not supposed to have a sac of fluid around your heart when it's beating, right? And if you do, it's not very efficient, and so it can really affect the ability for that heart to kind of expand into that area, and it can put excess pressure on the heart. So that's really the problem. So it's this accumulation of fluid, pus, so it could be part of an infection or inflammatory response, or blood, so there could be something that's some kind of hemorrhage or something. So something is causing fluid to collect or in that pericardial sac around the heart. Now, there's something called pulsus paradoxicus, which is an indicator, and you can tell that it's tamponade because you will see a greater than 10 millimeter of mercury decrease in blood pressure during inspiration. So when you breathe in, your lungs expand and they increase pressure on the heart even more, it's going to affect cardiac function even more, and it's going to cause blood pressure to drop during inspiration when you breathe in, and that's called pulsus paradoxicus. And really, the cardiac tamponade can happen during coronary surgeries or trauma. Okay, so that's going to be where that hemorrhage may have taken place, or infection may have taken place. So it does occur. We say not infrequent. So it's not really frequent, but it's not infrequent either. I don't know. So, but that's cardiac tamponade. So now we're going to talk about the actual muscle layer. Okay, so that was the outer layer. Now we're going to talk about the muscle layer. And so these can be categorized as cardiomyopathy. Of course, the myo referring to muscle. Okay, so we moved from the pericardial, now we're in the myocardium. So cardiomyopathies, and we're going to talk about two of these, dilated and hypertrophic. So dilated, and that's going to kind of take us back. So we're going to look at that one first. And dilated, remember when we were talking about how when the heart is stretched out too much, that wall kind of gets thinner and weaker. Well, this is a pathology that where this happens. Okay, so so the chamber walls are thin, extended, or dilated. That's why it's called dilated cardiomyopathy. And weak. They can't sufficiently empty the ventricles, and that leads to poor cardiac output. The output from your heart is going to be reduced. This is the leading cause of heart transplants, okay, which I found interesting when I found that out. Leading cause of heart transplants. The causes can be a lot of different things. It can be genetic, it can be infectious, or we just don't even know. But we do know that it happens, and that it's reducing cardiac output, and it's a form of your heart is in a sense be failing. Okay, and so it needs to be, like we said, it needs to be replaced. So you might see an enlargement, or you will see an enlargement because it's dilated. So the heart is enlarged 2 to 3 times with a flabby dilation of all 4 chambers. So instead of being thick and muscular and firm, it's weaker and it's more loose. Okay, of all 4 chambers. So manifestations the same as heart failure. So if you're talking about trying to move blood from the left ventricle and get it out to the body and it can't do it, then remember it's going to back up into the lungs, and that's what we call congestion. Okay? So a lot of times it's called congestive cardiomyopathy because it's backing up, fluid is backing up back to the lungs. Okay, that's a lung. All right. So also, when you have any kind of interruption in blood flow, blood's not flowing the way it's supposed to, or it's pooling because it can't empty all the way, then there's a risk for small clot formation, some platelet aggregation, and then that can move on to become an embolus. Ejection fraction less than 25%. Okay? Normally, your heart pumps out about half of the blood that's in the ventricle. In this case, it's only able to pump out about a fourth of the blood that's in the ventricle, and that's not a good thing. All right, so what about hypertrophic? Okay, hypertrophic or hypertrophy, left ventricular hypertrophy. So that's something that we hear about sometimes, LVH, left ventricular hypertrophy. This is when actually we go the other way. The ventricle walls are thickened, okay? And when they're thickened, and you can kind of see it from this picture here, when they're thickened, there's less room for blood, okay? So you might be thinking, oh, I've got a nice, thick, strong heart ventricle. But the trouble is that it tends to grow within that cavity, within the chamber itself, and it restricts how much blood can move into there. So your preload's going to be lower. So abnormal diastolic filling, okay? That means that you can't, during diastole, when the heart is relaxing, you're not going to be able to pull as much blood into it. That's what we mean by abnormal, so reduced preload. Arrhythmias can happen. You can actually see this sometimes on an EKG. You might see a higher QRST complex, or the R wave. So that might be changed. Plus, we're talking about depolarization, repolarization all the way along, so it could actually interfere with a number of different things. Often associated with increased afterload from atherosclerosis. So what that means is that as the ventricle, we'll go up to the normal one here, is trying to push blood into the aorta, if you have some kind of stenosis, valvular stenosis, or you have atherosclerosis, but something is not allowing it to move through, that's going to make that left atrium, in this case, work harder. And if it has to work harder, it's going to adapt, and it's going to become larger, just like any other muscle that you work out. Okay? So often associated with increased afterload. So that afterload, remember, is that pressure it has to push against. Okay? So when it's genetic, it's the most common cause of sudden death in young athletes. So I often think about that because on a regular basis, you hear about a student, a football player, tennis player, soccer player, somebody just dies unexpectedly. And a lot of times it's because they had a genetic form of this where the cardiac muscle was too large to begin with, and it was undiagnosed. They didn't notice it. So it's autosomal dominant trait. So the manifestations: increased breathing rate, dyspnea, chest pain, fainting, and it's usually post-exertional. It's when you're putting it under pressure. Okay, so we went from the outer layer, the pericardium, to the myocardium, muscular layer. So now we're going to move to the endocardium, and we're going to focus mainly on valves, so valvular heart diseases, so stenosis of valves. So now our valves are supposed to open just right and then close just right as well. Okay, so as blood's trying to move through there, those valves are going to pop open and then they're going to close, and that's when everything is working right. However, not everything works right all the time, as we know, otherwise I wouldn't have a job and you wouldn't be taking this class. So stenosis is a narrowing of those valves. So narrowing of the valve opening so it does not open properly. That's stenosis. That's just the meaning of the word stenosis. Now, we like to call this incompetent. We were talking about that with veins and incompetent valves in the veins earlier. But now we're talking about the heart, so it's kind of the same thing. The veins are incompetent. They're not closing the way that they're supposed to close, okay? So they're supposed to close it off and block any blood from flowing backwards. Well, if they're incompetent, blood is going to flow backwards, okay? And that's called regurgitation. If somebody or if your cat regurgitates, that means it ate something and then it puked it back up again, okay? So that's what these valves, I guess, are doing. The blood's going through and then it's puking it back up again. And so it's going the wrong direction. So distortion of the valve, so it doesn't close properly, permits backwards flow to occur when the valve should be closed. That's regurgitation. Prolapse is when the valves themselves will actually go back the wrong way. They're supposed to open one direction and then close, but in the case of a prolapse, the pressure, like if your ventricle squeezes, it could actually push that mitral valve back open the other direction, and then of course you're going to have regurgitation. Blood is going to flow the wrong way. Okay, so prolapse when the valve flaps are pushed in the wrong direction. Okay, so if we kind of look at some of these pictures, we can see the normal valve's supposed to be open, then it's supposed to be closed, but a stenosis means that when it's supposed to be open, it doesn't open enough. When it's regurgitant, that means that it's supposed to be closed, but it's still open. Okay, so that's an insufficient valve. So what are the disorders? Well, they're really based on those terms. Mitral valve disorders, mitral valve stenosis. Okay, it's supposed to be open, it's not open enough. Mitral valve regurgitation, it's supposed to be closed, but it's a little bit open. Mitral valve prolapse, it flaps the wrong way. Okay, so those kind of make sense. Aortic valve disorders, so that's blood flowing from the ventricle. The ventricle squeezes, moves out through the aortic valve into the aorta. Well, that can be narrowed a little bit too, which, by the way, can lead to left ventricular hypertrophy. So stenotic aortic valve or aortic valve regurgitation, it pushes actually back the blood reverses direction. Okay, we don't really see prolapse in that area because the aorta, when blood moves into the aorta, it's really usually not enough pressure to push it back the other direction, but it can push some blood flow back through there if the valve doesn't close all the way. The tricuspid, and pulmonary valves, they're under a lot less pressure. The whole right side of the heart is under less pressure, and so they can get disease, but it's rare. It's rare to see that for whatever reason. Okay, and then I guess the hard part about this, in addition to just knowing the terms and what those terms mean, is figuring out how blood flow is affected by these valve disorders. And that's going to kind of move us nicely into heart failure, which is going to be the next part of this.